Welcome. I'm Dr. Chad Achenbach. I'm the Associate Director for the Havey Institute for Global Health. And I wanted to briefly introduce today's session and just thank you all for taking the time to join us this afternoon. This is our latest installment of the Havey Institute for Global Health's IGH seminar series. So the title of the talk today is The Global Quality Chasm. What is the role of quality improvement in advancing global maternal and newborn health equity and scale? I just wanted to have you all take a moment and make sure that you follow IGH on Facebook and Twitter. Our handle is @FSM Global Health. In addition, we welcome you to become an Institute member to receive access to specialized resources and services that support global health research infrastructure. For more information on that, you can visit our website at globalhealth.northwestern.edu/members. So to introduce our speaker today, I'm going to hand it over to Dr. Lisa Hirschhorn, who knows our speaker well. Lisa is the director of our Center for Global Primary Care and the current interim director for the Center for Global Cardiovascular Health. Lisa, take it away.
Thanks so much, Chad. And I'm absolutely delighted to introduce Hema as a speaker, and want to sort of first of all thank her for her time working to join us here. Hema currently serves as the Senior Project Officer for Newborn Health on the Maternal, Newborn, and Child Health team at the Bill and Melinda Gates Foundation, where she leads the team's strategic, technical guidance and investment portfolio for newborn health. But I'm going to go back a little bit in time to when her pathway started, which is soon after that is when I actually got to know Hema. So after finishing her residency in pediatrics at UCSF, she completed a fellowship in general academic pediatrics at Boston Medical Center, as well as a master's in health service research at their School of Public Health. And during that time, I actually had the pleasure of actually beginning to work with Hema, where she taught me everything that I ever could possibly know about neonatal health, as well as really supporting the work in quality improvement. From 2012 to 2016, she served as the Director of Pediatrics for Partners In Health-Rwanda, living in rural Eastern Rwanda, where she led the design, implementation, evaluation of innovative public sector programs, addressing a lot of gaps in care, but particularly focusing on small and sick newborns, an area where really the global attention had not yet been turned, as well as improving neonatal survival and, importantly, early childhood development. And I don't know if she's going to have time to talk about that, but this was going to this concept of Alive and Thrive. Following that, she served as the Executive Director for Institute for Healthcare Improvement in Ethiopia, where she oversaw the technical and operational aspects of a large-scale improvement program that she'll be talking about in part today, again, funded by the Bill and Melinda Gates Foundation. And the idea was to support the Federal Ministry of Health implementation of their national healthcare quality strategy, again, to improve quality of maternal as well as newborn care and outcomes. She currently not only is at the foundation, but also holds academic appointments at the Brigham and Women's Hospital Division of Global Health Equity and Boston Children's Hospital, Harvard Medical School, and really focuses on bridging the delivery gap in child and newborn health interventions in resource-limited settings, improving quality care, and very much focusing on pathways to scale. Her global health leadership integrates clinical and public health neonatal expertise, large-scale program design and implementation, health system improvement, implementation research with an equity lens. And it's really been an honor and a pleasure to be collaborating with Hema over now, I guess, over 10 years. There'll be time for questions following the presentation, and we welcome you to submit these questions through the Q&A feature at the bottom right corner throughout the presentation. And now, Dr. Magge, or Hema, I will turn it over to you.
Thank you so much, Lisa. That is an incredibly kind and generous introduction. It has been such a pleasure and an honor learning from you over so many years. Let me get into, okay, I think that should be correct now. So thank you so much. It's really such an honor to be here with all of you today. And thank you to the organizers and to Lisa for inviting me here. So, you know, as Chad and Lisa said, my task today is really to talk about the global quality chasm, and then zeroing in on what is the role of quality improvement in advancing maternal and newborn health, both scale as well as with equity. Actually, so, I think a couple things that I'm hoping that you all come away with by the end of this conversation. One is a real understanding of the clarion call that exists to address the quality chasm in low and middle income countries, especially, but also globally. This is a universal issue that no longer can we just say that the issue is access to care, but that once you reach care, there is a huge gap in quality of services, and that gap in quality does not affect all people equally, and that marginalized populations experience that gap even more starkly than others. Two, that I hope that everyone comes away with a passion for maternal and newborn health. Really, this is such a universal issue. All of us have some connection with the process of birth, whether directly, indirectly, as a family member, a friend, and that far too many women and babies die, and it's just really not okay anymore in the world. And lastly, that there is a role and there are tools that we have to rigorously try to improve quality, and that using frameworks can be helpful to addressing quality in the health system through multi-level methods, and that achieving scale is possible, and achieving scale that does not come at the cost of equity has to be a priority, and that it requires an intentional approach. So quickly, that kind of global framing, I'm sure this group is all familiar with the Sustainable Development Goals, and just to kind of couch this in the SDG that's focused on universal health coverage, which really is about achieving that coverage for all of the core services that people need, and highlighting that unless that care is of sufficient quality, coverage is ineffective and often can even do harm. And what is quality care? Just to ground us in the Institute of Medicine definition of it being accessible, timely, safe, effective, patient and person-centered, efficient, and equitable. And I think it's important to call out that two of these domains are probably the most, have often been neglected in quality improvement programs. And those would be being person-centered as well as being equitable. And when we look at the burden of disease that we're talking about, there have been a number of really important reports that have come out over the past few years, in particular the Lancet Commission on High Quality Health Systems, which Lisa was a leader of and a global commissioner, really helped to highlight this burden of disease and really citing that poor quality accounts for 10 to 15% of all deaths in low and middle income countries. And three different reports, the Lancet Commission was one of them, but three different reports actually came up with estimates that were very similar to each other, between 6 and 8 million deaths annually. And that the vast burden of this disease affects sub-Saharan Africa, maternal deaths, child deaths, and newborn deaths. So when we zero in then on maternal and newborn health, this has been really recognized by the global newborn community. And in 2015, a large group kind of gathered together and developed and launched the Every Newborn Action Plan. And that started in 2015. It had large kind of core metrics and guidance that were really focused mostly on coverage and mostly at the community level. But in 2020, I think it was an important sort of evolution happened, was really trying to say coverage is not enough, acknowledge the same quality chasm, and really start focusing on what needs to happen, what type of coverage of care needs to happen, where it needs to happen at the subnational level to really try to drive equitable outcomes. I mean, and so when in terms of the burden of disease, the latest UN IGMI report actually just came out maybe last month, and not showing, I mean, some progress for sure, but still a humongous burden of disease of over 2 million stillbirths every year in low and middle income in the world, as well as 2 million newborn deaths, so deaths before 28 days of life, and that the vast majority and the burden of that disease occurs in 10 countries of the world, in sub-Saharan Africa and Asia. And so that Every Newborn Action Plan helps to provide a roadmap to trying to end those preventable deaths and achieve both with targets by 2020, by the SDG targets by 2030. And so this really kind of calls out that burden of disease being in the darkest green in Africa and Asia, and that the causes of neonatal mortality are largely driven by complications due to being born too early, so preterm, or too small, low birth weight. Sometimes those are kind of, there's a duality of those phenotypes. As well as intrapartum complications where birth asphyxia. So that's usually due to poor labor management and inability to be born at the right time when you have fetal distress, as well as access to neonatal resuscitation. And then thirdly, to sepsis and other infectious conditions. So all of these are largely preventable with high quality care. And as I mentioned, that the latest ENAP targets that came out in 2020 add this really important coverage target number 4, which really focuses in on that highest burden of disease happening among small and sick newborns. And so the target is that 80% of countries have national implementation plans that really focus on small and sick newborn care, and that countries achieve 80% district coverage of level 2 neonatal care with CPAP. It sounds very granular, but it's really based on data of what interventions are needed at the population level for babies that are sick or small to survive, and for countries to actually achieve their SDG targets in neonatal mortality. So now that you have that global context, I'm going to fly over to Ethiopia, where I really had the honor of working and living for 4 years prior to joining the Bill and Melinda Gates Foundation. And this was an opportunity, as Lisa said, where I was part of the Institute for Healthcare Improvement, and we had the opportunity at the invitation of the Federal Ministry of Health to support them and partner on trying to implement their national quality transformation agenda. So Ethiopia had established their health sector transformation plan with 5 pillars, and one of those pillars, and this was back in 2016, was quality. And so it's really kind of getting there, really at the leading edge of this of this mission. And so they said we need some partners to kind of work together on adapting what this will look like. And so in terms, for those of you who aren't familiar with Ethiopia, Ethiopia is an incredible country. Has the second most populous country in Africa, landlocked, and surrounded by Eritrea, Somalia, Sudan, and it has while it is a low-income country, has also had some really strong and important progress when it comes to maternal and child health, primarily through the development of a health extension program with paid community health workers. And so that was one of the kind of key primary care reforms that preceded this focus on quality. And I think that part of what the Ministry of Health was seeing, and the health minister at the time, was that need to move beyond access and really bring in quality care into that access. Recognizing this is a complex environment, complex ethnic, political, socioeconomic environment with swaths of the country, with small urban centers like Addis Ababa, not small, but that's the main city, but that the vast majority of the population lives in rural agrarian areas, and then a smaller but large landmass of pastoral, very rural, nomadic communities. So in that context was a multi-tiered health system with, as in the green, the primary healthcare level. So you'll see at the health post and below is the health extension worker. Those are community health workers, nurse-led health centers. And then your primary hospital. So that's the first point of care with doctors, and where in theory sort of your access to definitive care and complications management should be, whether it's cesarean section for mothers and babies, your life-saving blood transfusion, or your neonatal, or excuse me, your CPAP and kangaroo mother care for small and sick babies, among other interventions. And then above that, you get to sort of more specialized care with perhaps specialist pediatricians and the like. And much like the rest of the world, as I called out globally, Ethiopia was no different. They're seeing major reductions in child mortality, that line in blue, but that green line of neonatal mortality was leveling off, and the greater proportion of child deaths, the greatest proportion was actually being led by deaths due to complications of prematurity. This graph shows that 2016, at 2019, the neonatal mortality was actually 31, so it really had plateaued. So we had, we were really working together with the Ministry of Health and trying to think, how do we start? And we were looking at this now. I had, as well, I'm a pediatrician, I was really touched with thinking about this from a health systems lens. And since the ministry had asked us to say, look, we've got this quality agenda and it has to drive improvement in real people's lives, and we want you to focus on maternal and newborn health as the kind of litmus test and drive results in that space, but we want the approach to be health systems embedded, and so not a vertical program. And so with that, we really were tasked with thinking about designing for scale from the start, really thinking about the role of leadership and governance in the health system, and recognizing that we're talking about a really and truly constrained health system in many geographies of the country, so that there would be a need to really look at the basics, the staff, skills, and the systems functioning. And because we were talking about quality involved, in order to be able, the quality is not a static concept, it's dynamic. You have to be able to look at your performance, monitor and understand it, try stuff, learn from it, and then continue to improve. So there had to be a learning system in this approach. And I think for anybody who has worked in quality, it's probably the most important aspect of any, it really is about behavior change. And behavior change means really culture change. So really trying to think about understanding the current culture of care provision, and then thinking about and understanding what will it take to get from where you are to a culture that really supports quality care provision. And that's really multifaceted and encompasses a lot of what we're going to talk about here. And that requires a data system that is reliable and provides data that you can actually look at and judge your performance by. And it requires being accountable to people. Health systems are not things that are there to report up, but ultimately they should be accountable to the people they serve. So this is kind of how we came at it. And then we said, you know, we used a framework. There are many frameworks that are out there to support scale, and everybody has their own framework that they like the most. I'm not proprietary in any way, but just gonna share what we found to be helpful was a scale up that IHI had developed that really kind of started, that we found very practical. And so it starts with setup, but then really thinking about what is the scalable unit within a health system that you're working in, that you want your intervention to be designed for. And then testing after kind of prototyping and figuring out what works in that unit, then doing a kind of intentional phased test of scale before going to full scale. Through this process is really, what's critical is embedded learning, so developing local implementation ideas, building the will and culture for change and spread, and that is a process that transcends these different phases. And finally, building that infrastructure and tools that are needed for scale-up. So all of this sounds a bit wonky, but I'll take you through the specific example of the program that we partnered with the ministry on in Ethiopia, and hopefully this will come a bit more to life. So this is we called it the Ethiopian Healthcare Quality Initiative, and the design framework was centered around the central aim of improving healthcare quality through an institutionalized culture of quality improvement. So that started with the establishment of a national quality strategy. So that was the strategy that would be aligned with the government's health sector transformation plan pillar for quality. And then in that strategy, it helped to establish governance structures at every level, at the federal, regional, and which is Ethiopia has a decentralized governance health system with governance at the regional level. And so establishing those structures at the federal, regional, and sub-regional levels, and then building the capabilities that are needed at all of those levels. So recognizing that the needs of a leader at a regional level, what the skills they need to lead and manage for quality are different and as important as the skills that are needed by frontline healthcare workers and nurses who are providing care and what quality improvement methods they need. And then pulling all this together, trying to test that approach through the demonstration in maternal and newborn health in that scalable unit. And so beginning with that prototyping phase, implementing this intervention in that scalable unit, a test of scale, so helping to create that blueprint and path for national scale up, and then that ongoing phased scale to ultimately achieve full coverage. So as I said, the first step was this national quality strategy, which was the first quality strategy was developed in 2016 and was really grounded in the kind of comprehensive full set of domains that needed to be addressed across the health sector. And then we focused on that intervention design kind of based in quality improvement methodologies and looking at the core target of improving maternal and neonatal facility-based mortality. And we use kind of standard QI tools. Many of you have probably seen driver diagrams, and we base the driver diagram in the 3 delays framework. This isn't really to get into the total details of that, but just to say that it is really important to ground any work you do in strong evidence-based technical rigor. And so that was kind of the beginning, and then it extended out into much more detailed drivers. And then the really kind of structuring the intervention around that scalable unit. So to call out in Ethiopia, what is a scalable unit of a health system? So for Ethiopia, it was what's called the Woreda, or the district. And this is basically it is a grouping of, there's an administrative lead at the district level, that primary district hospital, sometimes supported by a referral hospital where you may have specialists, but this primary hospital is where C-sections, neonatal care should be able to be provided at the population level coverage, and then supported by nurse-led health centers for basic preventive and promotive care, as well as more further outreach at health posts that are co-located in closer to communities with health extension workers, community health workers making home visits for that preventive promotive care as well. And so all of this is the unit of the health system that really should be accountable to that full catchment area population for their health. So that was the scalable unit that was defined. And then the phased approach was to try to prototype in each of the 4 major agrarian regions of the country, Tigray, Amhara, Oromia, and the southern region, but also recognizing that there are big portions geographically, but even if a small portion of the population in pastoral regions, which fundamentally have a different way of engaging with the health system. So we said that we needed to really try and to prototype an approach that might work in a pastoral region. So worked in Afar as well, the Afar region. So that was that kind of equity intentional approach. That scale has to be done, it has to be achieved in a way that is not at the cost of equity and leaving those who have already have some of the worst outcomes further behind. So we were planning for that first phase and then this test of scale. And in the test of scale, moving from 1 to a proportional kind of the rule of 5s, 1 to 5 or to some kind of related number of what it does. and tried to also get some sampling of different geographic archetypes of agrarian, urban, or semi-urban and pastoral geographies. The intervention itself was using an improvement collaborative approach, and this was really based on what the ministry had already set out in their strategy, that they wanted districts. They had review meetings where they're supposed to be using their data that were routinely collected at facilities and using them for some type of quality understanding and improvement. That said, oftentimes that is that is more of an accountability and sometimes data for punishment than data for improvement. And so, but it gave a scaffolding upon which we could start working towards that culture of quality. And so the intervention was designed around that kind of standard improvement collaborative approach, first understanding that focus area, defining your metrics that would represent those key processes of care, identifying the core leadership. So this was kind of in that QI governance space, and making sure they had the skills that would be needed to lead this work. And then supporting facilities in conducting their own baseline assessments to understand their baseline quality performance in this key core in the sort of priority area of maternal and newborn health. And then this focus on addressing gaps in basic clinical skills and supplies, knowing that you can't really PDSA your way out of not having the sufficient skills in neonatal resuscitation. So you had to do some gap filling on that sense and clinical skills and mentorship. But then coming into these first learning sessions, so this is where teams were identified at all of the facilities, multidisciplinary nurses, community members, and importantly, and community health workers. And then at hospitals, including clinical obstetrics and neonatal staff and surgical staff, coming together, looking at their data, identifying the problems, applying their QI methods, and starting to define strategies that they want to test between sessions. And that's when in the action period where the important work happens, where they're back in their routine work and trying to actually do their QI work as part of their routine clinical care provision. And they received QI coaching and clinical mentorship to try to support them in this work. And then they come back together and share their learnings. Through that process, there's sort of a rapid cycle sharing of ideas and a large number of change ideas that can get tested over time. Through that process, then there's sort of at the end, we're able to harvest the most quantitatively and qualitatively successful change ideas for further sharing, spread, and dissemination. But that was the prototyping. And so once that prototyping was done, the idea was then to move to a test of scale. And so all these leaders that were engaged in the prototype knew this next phase was coming. And so the idea was that their ownership was being built through the process, and that in the test of scale, each of these core elements, after having that proof of concept in the prototype, would be integrated into routine structures. So there were already government-funded WREDA review meetings. So that's what the learning sessions were planned to become. The trainings were going to be provided by regional health bureau QI leaders, not IHI staff. And mentorship was done by district level or WREDA level coaching teams, who they themselves were identified and trained by those regional QI teams, and not with IHI staff moving much further into the background. The measurement framework was very intentional. And I show this not to get into the details, but to say that it's based on the key processes of antenatal delivery and postnatal care that were the targets for improvement, and that indicators were selected very carefully to try to maximize what was possible through the existing HMIS, or the routine data collection that existed in the government system. But recognizing that those were fairly limited to coverage, we also used the opportunity to try to innovate some content of care using the concept of bundling core interventions. And the government had decided they wanted to use the Safe Childbirth Checklist, and so we supported the use of kind of bundling core components of that together and measuring care delivery in content bundles. And then with the impact to ultimately be seen in maternal and newborn deaths and stillbirths. So we had a wonderfully and beautifully designed program. We did so ourselves. Of course, every system, this is one of my favorite quality improvement quotes, is that every system is perfectly designed to get the results that it gets. And so here is an example of a health center in the middle of Amhara region and during the rainy season. And so this is the reality in which we are working. And I just sort of say that because I think it's important to really think about how, about context and how principles and methods can be applied and adapted to be relevant to whom you're serving. So this is a really quite a stark environment, but that said, it did not mean that these methods were not useful. I think what it meant, though, is that improvement tools can give us a way to make systems better, and it takes intentionality. And so what it did was it helped bring, what we found is that it helped bring the right people together to solve problems. In those learning sessions, you were bringing together frontline care providers, community members, together with district leadership, and then using data to identify problems, and then kind of identifying together who could solve those problems. In a way, it helps to create some accountability, but in a safe way. And so we found it, one of the ways that it can be incredibly helpful is flattening hierarchies, listening to patients and those at the front lines, and doing it in this learning environment. It allowed you to both innovate and test changes within the resources that facilities had, because they did have some, I think a lot of facilities ultimately had low caseloads in the beginning. And so they actually had some time and some funds to start innovating and thinking about ideas. But at the same time, as you said, no PDSA will get you out of the situation of that picture. And so what it also does was empowering patients and providers to use data to advocate effectively for solutions that really required higher level intervention, like electricity, like power, like roads, outside of any individual facility's resource. So you're working beyond the kind of traditional application of quality improvement methods, which is often considered to be very micro or facility level, but really working more at that meso level or that district level, and then more macro levels by that learning system that connects up to the regional and federal levels. And so just taking a quick look, to say that as a quality improvement program, we really also it's important to look at the implementation outcomes of the program itself as you're going and be learning as you go. So from a strategy perspective, just to kind of go through some of those outcomes, the strategy was developed and implemented and supported implementation review. Quality improvement collaboratives, 26 were introduced across 155 health centers, 35 hospitals, included over 700 health posts in these 5 regions of the country, and including 35 districts. And in terms of skills building, one of the, there were many healthcare workers trained through this process, but training is not enough. And that was really important was that in that transition from prototyping to that test of scale is that the training, the materials were owned entirely by the Ministry of Health, and the cadre of kind of trainers and experts who would then be applying those skills on a very routine basis as part of their job descriptions was embedded into the Ministry of Health and Regional Health Bureau structures. So there are many changes that were implemented through the time of that prototype and test of scale phases. And just to kind of shed a little bit of light on them, they involved, here's an image of a QI coach kind of working with frontline providers. So that's an example of sort of the coaching and mentorship. We introduced a focus on respectful maternity care, using patient testimonials as a way of catalyzing conversation really amongst QI teams and frontline care providers to really reflect on their role in providing quality and respectful care, and then incorporating that into the change ideas and quality improvement projects they were designing. There were change ideas that were introduced around task shifting, sharing of resources across facilities, lab, reagents, even staff, and nursing versus lab techs, because that was found to be a limitation. There was a key area that I'll share a little bit more later around supporting that level 2 neonatal care with CPAP at that district hospital or primary hospital level. And then really focusing on engaging communities to really hear their issues, priorities, and problems, leveraging some of the existing structures that existed to listen to women and what mattered to them. There were a number of innovative ideas that would come out of those conversations with women, particularly around trying to raise funds for renovations and improvements to the maternity waiting homes, which were a key intervention that had been introduced by the ministry to provide women a kind of proximal place to health facilities to be able to come before labor onset, so that they would be closer to a health center or hospital or a safer place to birth when labor came on. Improving patient-provider communication, and as I said, providing avenues for district and facility leaders to really listen to women and their experiences with the healthcare system. So some of the key themes, as I said, was empowerment at the front lines. We really had to support clinical skills. You can't provide care through that clinical skills has to be there at the start, and it's the foundation for any system improvement. So this is just an example of some of the clinical skills practice that was happening with neonatal resuscitation, both during initial training, but especially during on-site mentorship. And then, as I mentioned, when you're looking at population health, and as we follow the data, you know that if you want to reduce neonatal mortality, you've got to be able to provide care, both for basic care at the community and health center level, but also you have to be able to identify sick and small babies and get them to level 2 neonatal care and access to essential interventions like CPAP, and that is a critical intervention to reducing mortality. And so a big part of improvement work ended up being advocacy and establishment of level 2 neonatal care. And that involved a lot of partnerships and collaborations kind of beyond our initial sort of planned scope, but that's what, we followed where the data took us. Targeted gap filling for essential commodities, as you said, the baseline assessment identified key gaps. We first tried to really support the health system, really trying to maximize what could be how systems changes could improve access to those key commodities, which solved most problems. And then we were open to requests for additional targeted funds when necessary to support filling some of those gaps. And finally, data. I think this was a critical piece. Very often, especially in constrained health systems, there is an assumption that you will have a data system to begin your improvements with. However, we knew that this was not always the case, and one of the first pieces of improvement is to assess the quality of the data that you're dealing with, and that also helps you start to understand the culture of data use. And so as an example, in at least one of the districts when we were starting, over the 14-month period of baseline data collection, there were 0 maternal or newborn deaths that had been reported in the official system. And that just everybody knew to be false. And so it gave an opportunity for really trying to think about what are the root causes of that poor data, knowing that some of it is cultural and culture of fear. Some of it is human error and all of the system, all the things that get introduced with an aggregated data collection system. And all that to say is it became an area of focused quality improvement in and of itself. And these were some of the strategies that were taken to improve data quality, which improved during the process of the improvement collaborative. This is just a dashboard to kind of show a little bit of a way of how, at the level of a program, we and the district leadership were looking at data across participating Ruras. So within every one of these small multiple graphs lived 10 to 15 facilities aggregating their data from the population level up in a given indicator. And so this Adama 1 Rura, these are all the Ruras in one region. And then aggregate it all up, you start to see some trends across the program as a whole. And most importantly, I'd say that one of the key kind of transformations that I think is most powerful in improvement is shifting power to patients, learning from community members to guide change ideas. And so this was done in a number of ways. Had to start first, figure out what healthcare workers and kind of the culture was ready for, because we want to make sure that women and families are safe in any kind of engagement. But by the sort of in the prototype phase towards the end, women and community members were participating in learning sessions. They were sharing their feedback on change ideas, what they thought mattered and would be acceptable to them and their families. Provider communication was a critical space of change ideas. This was a health center director speaking to a pregnant woman outside of her antenatal care visit room. Health center staff here were focused on kind of basic renovations using their own funds to repaint maternity rooms, create locally constructed barriers to improve privacy and cleanliness. They did similar types of work within maternity waiting homes. And you know, this image on the right always makes me happy. It was from a visit to a participating Rura in the rural south of the country, and it was a pastoral region. And just when you walk into a room and you see women smiling and happy and interacting and playing music, you just have a sense that there's good quality there. And I think that's kind of one of the important things to keep in mind. And listening to patients, you know, in the left here is an image of listening to women who are staying in this maternity waiting home, but also to people. People are patients, patients are people. And on the right here is an Afari clan leader whom I met at a coffee shop on the street, and he had a lot to say about the quality of health system that he had experienced for his many children, and with his wife. And so those are really important people and encounters to learn from. And through all this, as I mentioned, that we're really able to kind of stretch some of the typical applications of QI. These are some of the examples of how through the use of data and the effective data for advocacy, some of the ways that leadership were engaged to solve some of those deeper systemic issues in the health system. So for example, in Tigray region, they secured grants from the regional government was able to then use the data to then mobilize more funds to build the NICUs at their primary hospitals that were engaged. In the South, they were able to increase their funding for mentorship and supervision from higher level hospitals to those district hospitals. They were able to solve some key gaps in equipment in ultrasound, water supply, and an X-ray machine. And in Oromia, they were able to then start actually working on the power dam that supplied electricity to one of the health centers that was in the improvement collaboratives. And then in terms of results, these are just a few examples of multiple results, but this is from the clinical bundles that I mentioned that looked at content of care. And so you see a fairly dramatic improvement in adherence to these core clinical bundles on admission before pushing and soon after birth. And this was across all of the 26 Waredas in the program. So in conclusion, really, you know, I think there were so many learnings, and I'd say that the kind of critical enabling factors was that this program was really designed by the Ministry of Health with IHI support, but it was really meeting their needs, aligned with their health sector transformation plan. And so that it had that kind of leadership and ownership from the start. Nothing was going to happen without health sector leadership. And then really critically, kind of on the other end of things, would be patient and community involvement, kind of open the door to being able to find systematic ways of engaging those who matter the most in all of this to guide and lead the priority setting for system improvement. And of course, there are many, many challenges, and that you have to note that the fragility of that basic health system infrastructure is real. You know, but that, you know, data is this is one of the many processes that can be used to help shed light on the issues and use that data for improvement when you can improve within your resources, but use that data for advocacy when you need it, to bring more resources in and really start and address some of those kind of core inequities at higher levels. And in this picture on the right is one of my favorites of an IHI mentor walking alongside a district manager. You probably may not know who's who, and that was part of the beauty of the partnership and the work. And they were on their way to a mentorship visit at a facility and decided they needed to walk the same path that women were being asked to walk, and that was what they did. So in conclusion, really hope that you see that it's necessary to take a broad view of quality with the patient at the center in any type of improvement program. And that applying quality planning principles is critical to success as much as those micro level improvements. And that using those principles can be used to mobilize resources for those key inputs that are beyond any single facility resources. Building that quality culture in a learning system is really instrumental, but that it can happen, and it takes time, but it takes time, patience, and partnership. And that finally designing for scale from the start with an intention, with an equity intentionality from the beginning is really very important to being able to achieve scale in a meaningful way. So with that, I'll end. I always like this quote, just sort of bringing us back to, that even sort of some of the biggest systems thinker and wonks in quality improvement, kind of the core motivation really came from that sacred mission of healthcare and love of patients and love for what we're trying to do here. So I'd like to close with that. So thank you so much.
Great, thank you so much, Hema. That was really wonderful, and I love the sort of starting globally and then really going down to the work and down to even the picture of those women laughing was just really wonderful, as opposed to the usual sort of suffering face that you usually see with people kind of sitting waiting to be served. We have 2 questions so far, and I would just encourage other people to please put any into the Q&A. So the first one is, clearly some people really want to know the nuts and bolts of what you did. And the first was, what was the time intervals between the action periods? And I'm going to actually expand on that a little bit. And if and how did you change that based on the work that you're doing in Ethiopia versus other places?
Yeah, great. I'm happy. Do you want to, I can just take that real quick.
Sure, yeah.
That, so we, things adjusted, I will say. We started with a goal for quarterly, and that was really largely based on the ministry's desire to kind of strike the right level of momentum. But sometimes with budgeting and really, because we were really trying to kind of titrate the external support to the minimum necessary to kind of catalyze the action, because it was really designing for the long haul. And so sometimes they extended as much as 6 months, but usually kind of in that 3 to 4 month period. So that was the time interval.
Great. The next question is actually a very interesting one, is who instructed the QI teams on CPAP, and how did you get buy-in and agreement on the proper measures to adopt?
Great question. So in terms of CPAP, there had been existing work but that already had been happening in the country, particularly with the Ethiopian Pediatric Society, to expand access and coverage to CPAP. And so CPAP was, so we really partnered with the Pediatric Society around establishing neonatal care. So we partnered with them, and they did their own assessment of the facilities that were in the hospitals that were engaged in the improvement collaboratives in the prototyping phase, and tried to connect them into kind of their existing work already with mentors, with pediatricians at higher level hospitals to support ongoing mentorship. And CPAP introduction the devices, there had been a government procurement using their money for a large number of commercially available devices, but also the Ethiopian Pediatric Society had been teaching and mentoring in ad hoc kind of how to make homegrown CPAP as well. So the mentorship was sort of titrated to the type of device that was used. But it's really important to recognize that CPAP is part of a system, not the only part of a system, as I'm sure whoever's asking that. So it was really about that kind of system of neonatal care.
Great. The next one is actually from Alexandra, whose name you might recognize. We know in Medi settings, one of the key challenges around maternal and neonatal care delivery is combating maternal perceptions that quality of care is poor. I'm not sure it's perceptions, it's also probably reality. What were some of the strategies or challenges around improving care seeking rates once the quality of care had operationally been improved?
Yeah, really important question. So glad you asked. I mean, so I think what is really important was engaging women in the intervention itself and starting small and learning as you go. When we first started opening up the conversation with district leaders in the prototyping phase around what do you think about bringing women into these QI teams, and the responses by and large were often very uncomfortable, very nervous. They won't understand this and that. And I think we just took it as there's not a readiness yet. We also wanted to be very careful of exposing women to potentially harmful or exploitative kind of interactions with people of higher power in their systems. So we kind of worked first with through the collaboratives on building that awareness and concept and conversation around respectful maternity care and what that looks like. And by the fourth learning session in the prototypes, there was just a much better interest openness for authentic engagement of community members. I think that engagement and outreach, people can tell when things are authentic. I mean, it's sort of very human and basic. You can tell when somebody really cares and is asking from a space of curiosity and authenticity. And I think that is the best way to build trust and to build some sense of it's worth trying. It's worth coming to seek care. Also, we asked specifically, they asked specifically what are your barriers? How can we address them? And started to systematically address them and start seeing increased coverage.
And now we're going to go to the lightning round. We have 3 questions, and if I can sneak a 4th one in, we really just have a few minutes. The first is from Gabriel, who is one of our PhD students from Abuja. Says, how were you able to address cultural issues where men are not allowed to attend to women with medical issues, yet there are few or no women trained to cover the gap? The second is, are there particular programs that you recommend for QI training for, I assume GPH is global health practitioners? Candace, please tell me if I'm wrong. Are there any that address the longstanding impact of Western colonialism and imperialism? And then from Robert Atilias, did you use the same tools to all levels? And if you have time, which you may not, would be really curious to thought, this is obviously also not just a quality a sort of clinical institution, but also a research institution. How do you think QI and research can mutually interact to improve what they're doing? So I've given you 4 questions and maybe 4 minutes or less.
Okay, I'll try to do a lightning round. All amazing questions. 1, I would say we were not able to fully address that cultural gap. I think you just hit the nail on the head of one of the core issues in the Afar region. I think that was a key issue of you had women where it was not culturally appropriate to be touched by men in the healthcare system, and you had healthcare workers who were largely men. And so I think, honestly, that was one of the core learnings, was to, and there were a few different ways of trying to address it. And I think that largely one of the key things was actually policy recommendations and trying to change the way that healthcare workers were allocated and moved and placed, and the incentives from the public health system to those what were considered hardship regions, so that there would be more women engaged. But it's a super complicated question and that I can't fully answer. The second was about QI courses, and there are many QI courses out there. I mean, I would be Remiss to not mention the IHI Open School, which are free courses and modules. I will say that you asked an incredibly important question about imperialism and colonialism. I have not found one place that addresses all of these pieces together in a comprehensive way. I do think that there are many among us and others who are trying to work on that. So your demand is really well noted and absolutely should be there. I know that there are many within Africa who have developed, there is something called the Ubora Institute based out of Ghana that leads quality improvement, quality management courses and mentorship and support that may be worth looking into, amongst others. But I'm happy to stay connected and brainstorm further. The last question, was there another question?
Did you use all tools on the same,
No.
the tools on the same level?
Nope, they were all adapted. QI methods were adapted for different levels of the health system and what you needed to do. Frontline healthcare workers needed different skills than district leaders and managers, but they needed to kind of be able to work in a symphony and harmony. And to your question, Lisa, about research and QI, it's so important. I think you have been an incredible teacher to me on how these methods are not competing, they are complementary. You have methods that you need for micro level, not necessarily generalizable, but very practical, real-time, rapid learning. And that's where I kind of think about quality improvement kind of methods. And then there's quality management principles that can be applied at higher levels. But throughout all of this, we had an embedded implementation research agenda as well. And that was sort of really preset certain questions that the government wanted to be answered in order to understand the process and feasibility of scale. So that involved costing, involved questions around that kind of scale up pace and process. And that happened, so we had kind of simultaneous protocols happening at once.
Great. There's one last question, but I think I'm going to try to see if I can send that to you. So maybe, Georgian, because you asked, can you share how you go about engaging community to be involved for QI? That's a much longer, but very, very important question and answer. So if you're able to send that to the organizers for the webinar, we can, if that's okay with you, Hema, link you up to get a little bit more detail on that. So I want to just thank everybody for attending, and very importantly, Hema, for giving us your time, for your insight and expertise. We invite you to join us next month for our next Institute of Global Health seminar taking place March 7th. The event will feature a presentation from Dr. Justine Davies, who's Professor of Global Health at Birmingham University, UK, visiting professor at WITS, as well as I love the term extraordinary professor. She actually is extraordinary at Stellenbosch as well. And so she'll be talking, does some really innovative work on trauma and access to quality injury care in low resource countries, both the work that she's done and future projects as well. Chad, handing it back over to you with probably no time left, or 1 minute.
No, I think you hit everything we wanted to mention at the end. Just thanking everyone and thanking Hema again for all her insights and expertise and joining us for our seminar today. And you can see the slide here. Please join us each month, every month on Tuesdays at noon. We'll be doing these seminar series. They're all fantastic speakers. So please register in advance so we have a good idea of who's going to join, and join us on social media and become a member. Thanks so much, everyone. And everyone have a great month.